following episode is brought to you by the American Urological Association. This episode features content from the AUA 2025 meeting in Las Vegas. For more information on how to claim CME credit for your participation or to view faculty disclosures, please visit the AUA University. This educational activity is supported by independent educational grants from Astellas, Janssen Biotech Inc., administered by Janssen Scientific Affairs LLC, Lantheus Medical Imaging, Novartis Pharmaceuticals Corporation, and Pfizer Inc.
Good morning. I'm Mike Cookson. I'm the director of this course, and this will be an intimate final day of the AUA update on advanced prostate cancer guidelines and beyond. I want to thank everybody again for getting up and attending us on this last day of the AUA and the early morning session. We've been doing this for multiple years now. We also run a full day course at the very beginning of the day before the AUA, so some of you may have had the opportunity to attend that. But the point is that's like 8 hours, and there's a lot to cover. This is a more condensed, hopefully user-friendly version for you all, and it's about a 2-hour setup. We have a great panel here once again this year. So Dr. Will Lawrence and Dr. Adam Keibel and Dr. David Gerard, and they'll all be imparting their wisdom on you. All of them have participated for many years in these courses and have input into the guidelines. And so with that, we will begin. What I'm going to do is sort of present an overview of the first part of the guidelines, and then Dr. Lawrence will present kind of the second part, and then we will go into a deeper dive with Dr. Gerard and Dr. Keibel. So this is a small group. We can be interactive, so don't hesitate if you have any questions to feel free to ask us. We know that prostate cancer remains the #1 cancer in the United States in men. It's a higher risk, obviously, in African-American men. We still, unfortunately, hold the #2 position in terms of cancer deaths. There was a short period of time where we fell to 3, but there has been, despite the improvements in our treatments, we've seen an uptick in the discovery and diagnosis of men with more advanced disease. So from to about 2013, it was pretty good news. And then somewhere around there, it started flipping back to where newly diagnosed men from just their screening tests were discovered to have either advanced or metastatic disease. Where I live in Oklahoma, we have a very rural state, and we see many people come forward with their very first PSA, and their PSAs are 50 or 100. The screening is not widely utilized in our state. Only about a third of men get that kind of screening. There's all kinds of confounders, like the confusion from the U.S. Preventive Task Force Services. There's access to care. There's a lot of education that needs to be done on the front end for primary care, as well as the advanced practice practitioners that see these patients at that first point of contact. So we are working to improve that, but the point is that we're going to be needing to use the tools that we talk about in this course for the next decade. We're not getting rid of advanced prostate cancer anytime soon, unfortunately. So again, the guidelines are pretty encompassing. We start with patients with biochemical recurrence after failed local therapy. So there's another guideline in another session that talks about, what about I've had radiation and I've failed, but I still have a prostate intact? Is there treatment available for that salvage setting? And those guidelines were released last year. We take the patients who've exhausted their local therapy and follow them through from recurrence to development of metastatic disease, and then castration resistance. So that's really the purpose of this. And we know on the panel that they don't update this often enough for you all. We advocate and lobby for that, but the purpose of these courses is really to fill in the gaps where they exist because they're not keeping up. We know and have known for many decades now that prostate cancer is highly sensitive to androgen response, and removal of androgens, androgen deprivation, is an effective initial form of therapy. And one of our few Nobel Prizes in urology, of course, was Dr. Huggins, and was able to show this back in the 1940s. And it's true that almost all prostate cancer initially, 90 to 95%, will respond to androgen deprivation, and that could be an orchiectomy, that could be an LHRH antagonist or agonist. But monotherapy alone is really only for the exceptional patient, can't afford, can't access, can't tolerate additional therapy. And I think you'll see throughout the morning here that treatment intensification has moved the needle, has improved survival. When they did the first LHRH testing, for example, the average response rate was 18 months, and then you progress to metastatic castrate resistance. We had very few options, and people lived in general about 3 years. Now we're seeing, men live average 5, 7, 9, 10 years through these treatments. So we've really expanded the ability beyond just the original, but you can't just rely on, well, I gave them monotherapy, they got a good PSA response. Sure, they will get it initially, but it will progress past that. So hopefully you'll get that out of this course today. So I'll start with a little bit on the biochemical recurrent patient who has exhausted local treatment. And so in your practice, it's recommended that when you have patients with rising PSAs, that you follow them, you monitor them, and I'm sure you do, usually in 6-month intervals for the PSA. Some may require a little tighter control if it's rising more quickly. And when you use that PSA over time, you develop a PSA velocity or PSA doubling time, and that doubling time kind of is a foreshadowing of what's going to happen with them. And so patients with rapid doubling times, usually defined as less than 12 months, less than 10 months, those patients are at significant risk for development of metastatic disease. We know this because people came forward in clinical trials about a decade ago, and they were trying to see if they were eligible for the trial, and they had a rising PSA, and they didn't qualify because they didn't have lesions in their bones. And they followed those, but those with those rapid doubling times, they quickly manifested within about 2 years or less, metastatic disease on conventional imaging. So that doubling time is going to tell you who is at high risk for a bad outcome. In addition to that, it's recommended that we follow them with imaging. And so this has evolved, but I think we all know that PSMA PET testing is the most sensitive and exquisite way to determine early metastatic potential. Conventional imaging is still available to patients, and if they need it, then that's what they'll do. But most of us preferentially, and the guidelines suggest that you would use PSMA PET testing for that. We don't reflexively put patients on hormonal therapy for all comers, so that's an important concept. Patients do get anxious when they have a rise in their PSA, but a PSA rise alone on a single number or without other indicators is usually not a trigger for treatment. And so we do recommend observation for those with slow rate of rise, but in the patients that we're going to consider androgen deprivation for, intermittent therapy is an option for these men. Before some of the newer studies that I'll get into in a minute, this is one of the few that was out there, and this looked at patients that had failed radiation therapy, and it randomized them to continuous monotherapy versus intermittent, and it showed that really they were very similar. So they used some statistical jargon like non-inferior, that kind of thing, but in the end, patients on this study who got intermittent therapy, and I think they waited till their PSAs came back to almost 4, which most of us would use a lower trigger for these days, but there was no difference in their ultimate outcome. So the possibility in this space for biochemical recurrent patients to do intermittent therapy was definitely shown early on. Up until recently, though, we really didn't have any extra therapy for them. So it was just monotherapy until recently, but 2 studies and others are coming looking at combining the use of AR-targeted therapy with the androgen deprivation in that enriched population that's at risk for development of metastatic disease. And so those studies have changed our treatment paradigm for men with rising PSAs after failed local therapy. The 2 studies I've shown are listed here, and they are similar, but there's some small differences. But what is common about them is that the PSA doubling time was quick, so less than 9 months. They all met the definitions for failure, so if you'd had surgery, and you're in the EMBARK study, the PSA was 1 or greater, and in the radiation failure patients, it was above nadir plus 2. So they met those conventional definitions of biochemical failure. And then in the EMBARK study, patients were randomized to leuprolide alone, which was with placebo, leuprolide or enzalutamide monotherapy. The patients were then treated for 9 months continuously, and then given the opportunity, if they had a good response based on their PSA, so in this study, if their PSA went to less than 0.2, then they were given the opportunity to go on intermittent therapy and a treatment suppression. Presto was a little bit different. The patients had prior prostatectomy with adjuvant or salvage radiation therapy. Their PSAs were about 0.5 and rising. Again, both of these studies did not include PSMA PET. They had conventional imaging. So that is a little bit of a nuance to this that you need to be aware of. In the Presto study, the patients were treated with ADT alone, ADT and apalutamide, or ADT, apalutamide, and abiraterone, sort of a 3-drug regimen, if you will. The endpoints were slightly different. EMBARK was metastasis-free survival, and then the Presto study was PSA progression-free survival. So I'll briefly go through the EMBARK study here, but again, there were 3 arms, and so patients were randomized to one of their 3 treatment arms, and they were followed. And what they found was that there was a significant improvement in the metastasis-free survival, almost by 50%, in patients treated with enzalutamide and an LHRH compared to LHRH alone. There also was improvement in the monotherapy arm over LHRH alone. So this was, what did we used to do? Everybody got a Lupron shot, for example. Now we know that adding an additional AR-targeted therapy would result in a significantly better outcome. There were other outcomes in the study, and you're welcome to read into either our handouts or go to the article in the New England Journal yourself and see. The overall survival data wasn't mature enough, so we can't say that we know that they'll live longer. I think that is not known, but certainly for staving off need for secondary treatments or chemotherapy and additional things like that, it was a positive. I think this is an important slide from the study, and it showed that about 90% of the patients reached that low PSA level. So if your patient doesn't really go down as low as he should, obviously you can continue to treat, and you don't have to do a intermittent or a suppression of therapy break. But 90% expectation, if you're on that combination, that you will get there. And then even better is that there was about an average of 20 months of time off drug. Everyone knows there's side effects to these medications. The patients undergo a lot of stress while they're on them. We can't get around that. But if you can give somebody 9 months to a year of a treatment, and then they go into a deep state of remission, and then almost 2 years before you have to retreat them, I think that also is a win. So that was what was demonstrated. You don't get as far with the monotherapy, and you can see that from this slide. There are side effects that are additive to these treatments, but definitely well tolerated. So the hot flashes is a common one, fatigue is a common one, and those are listed here. But so I think it's important that there is a shared decision and a risk-benefit discussion with these patients. But again, in those patients that are at high risk for metastasis, this is an effective treatment to stave off and reduce the time interval to that. Again, the Presto study was the second study, and I already kind of outlined the trial, but again, it's monotherapy versus a combination of apalutamide and abiraterone. And in both of the intensification added treatment, there was significant PSA progression-free outcome there, and you can see that from the graphs. They did little sub-testing, like what if your PSA doubling time was a little bit less, a little bit more? So in all the subgroups, it still panned out that there was benefit to the combination treatment. So 2 studies demonstrating benefit of adding additional AR-targeted therapy to traditional monotherapy in these patients after salvage. So that's an important addition to the guidelines. In the next part of the guidelines is really about metastatic disease. So what if you are discovered to have metastatic disease, how should we treat you? And so obviously it is part of the process to obtain PSAs, get conventional imaging. PSMA PET imaging is often done. The reason for the conventional imaging is a lot of the trials were done and use that. And so the volume of cancer impacted a lot of the recommendations for treatment. High volume, low volume. Is it de novo metastatic, or is it a progressive situation? So symptomatic assessment is important too. Many of the patients are, if they're really debilitated and there's a lot of comorbidities and frailty, if it's not associated with their cancer, then it may not improve with treatment. So all those things have to be assessed, and they're recommended within the guidelines. The extent of the disease, that's not a new concept though. It's been around since some of the earlier trials, even looking at the first generation anti-androgens like flutamide and stuff. And in one of these early SWOG studies, they knew that it didn't really matter whether you were treated with that first generation plus LH or orchiectomy alone, your outcome was really largely going to be based on the burden of your disease. So the amount of disease that you present with is a powerful predictor of how you'll do. And that was used in the charted study, which I'll show you briefly, where they gave docetaxel chemotherapy, and there were significant differences in the response to the patients and how they benefited based on the burden of their disease. At one of our plenaries earlier in the week, you probably heard, but genetic testing is highly recommended. So in the earlier disease state, I think Dr. Keibel was our moderator for that. But in patients with like grade group 3 disease, unfavorable intermediate, high risk, newly diagnosed, localized, they're recommended to undergo germline testing. Certainly those patients that have family histories, not just prostate, but if you start hearing breast cancer, ovarian cancer, lung cancer, those should trip up your antenna to consider germline testing. But it is definitely recommended in patients with metastatic disease. So if they haven't had germline testing, that can be weaved in. When you do that, that's an art, right? Like you're meeting them, you're telling them you have this cancer, we're going to have to do these treatments have side effects, we've got some testing to do. It doesn't have to be the very first visit, but it definitely should be in there in the mix. And that's important for multiple reasons, which you'll hear about a little bit later. But there's treatments that are related and linked to these that are moving up further and closer to the disease state, not just on the second, third line of metastatic CRPC. And in addition, there's a cascade benefit for their families that need to be discovered. And so, for example, I've had patients whose daughters had breast cancer and they didn't know and they didn't get tested. And so you can help them from their family standpoint as well. So germline testing is important. It's seen, in about 10 to 11% in this landmark study of newly diagnosed metastatic patients. And then if you look at the castration-resistant population, somewhere in the range of about 25%. So it is the first entree, if you will, into the testing. We can talk a little bit later about somatic testing and looking for changes that occur as tumors undergo selective pressure. That's different than what you inherited, but the germline testing is highly recommended. So it's really thought that ADT is the first step. It's the backbone, and it can be an agonist or an antagonist, but it is recommended. And then in addition to that, that's not enough. So then you're talking about adding an additional therapy, a doublet, if you will, from an AR standpoint to try and attack the cancer with a better outcome. And then in some patients, which we'll go into, depending on their presentation, high risk, high volume, de novo, metastatic, they may be candidates for chemotherapy in addition. So that's a triple therapy, if you will. So these are kind of a menu, simplistic menu, because I need to be simple, but ADT, docetaxel is an option, ADT plus androgen-targeted therapies, and they're listed there. Really, all of those have efficacy in this space. And then for patients who we really feel are in need of triple therapy, we certainly can add to that. This was the original study, and it's really almost a decade old now, but it was a paradigm change for us. Before we had chemotherapy in the mix that was effective. We had things like mitoxantrone. We didn't really even have medical oncologists interested in our space. Like there was nothing to do. They like lung cancer. They like this, that, because they just really didn't have much to offer. But this study, based on the original signals we got in the castration-resistant world, which was around 3 months of survival benefit on the far end, but then the drugs got moved up into the metastatic space, and we saw a rapid improvement in survival for these patients. Again, they did a high volume definition, which is listed there, but the reason for that was they originally started out just to do high volume patients, but they had some trial enrollment issues, so they included all comers eventually, and they powered it for survival. And lo and behold, there was a significant difference over monotherapy when you combine with chemotherapy 6 cycles in patients, and that was the big discovery, and it was a kind of a very significant move forward. When they looked at the way that they had enrolled the patients based on the disease volume, not only was there a significant overall benefit, but the benefit was most profound in those patients with high volume disease. So about 12 months for all comers, but it was 18 months survival benefit in the high volume metastatic setting. And they really couldn't demonstrate that much of a benefit in the low volume metastatic setting. So that kind of cooled the jets on the low volume patients in the United States. But certainly the high volume patients were candidates. This was not the only study. So Stampede was the European version of the same trial design that showed significant survival benefit adding to ADT alone. And you can see the Kaplan-Meier curves there. So that was the chemo. Then there was, what about these oral agents? And again, all of them started out on the far end in the castration-resistant and then slowly moved their way back. But 2 landmark studies using abiraterone were included in patients with metastatic disease, so adding that to the mix. One was called Latitude, and again showed overall survival benefit for patients using the addition of abiraterone. We used to think, once you've suppressed the hormonal therapy, you've done all you can do, but that wasn't true. And so contributions of circulating androgens from the adrenal gland were adding to the growth of the tumor, and this allowed for further benefit. This was the Stampede version, so there was a Latitude and a Stampede, same design, but again, same result, overall survival benefit by adding an additional AR-targeted therapy. Then what about the androgen blockers? So the novel hormonal therapies that were sort of second generation blockers that have about 10 times more potency than the traditional flutamide medication, for example. So in the Titan study, they used apalutamide, and again, significant survival advantage over ADT monotherapy alone. There were a couple studies with enzalutamide. One was called ARCHES. This was originally, I think, demonstrated radiographic progression-free, but with further follow-up, it did also show overall survival. And then Enzamet was a second enzalutamide study that did show overall survival too. And then this year, for the newest study is Aranote, and Aranote used darolutamide. So it's kind of the third drug to be studied in that space, but again, now it shows benefit, and it didn't have an indication before. I think the FDA approval is forthcoming for that based on the data from here. But darolutamide, which I'll talk about in a minute, has approval as triple therapy, and it has now shown efficacy and benefit in patients with metastatic disease. So you have a lot of options to choose from on the oral agent side for those patients that are going to do doublet therapy. But there are patients who can benefit from addition of the hormonal ADT base, the AR targeted therapy, and chemotherapy on top of that. So in the Peace 1 study, which has multiple arms to it, that orange arm there is the addition of abiraterone to standard of care, and the standard of care after the charted study was chemo and ADT, and they powered it for survival, and it did show significant benefit of a triple therapy for patients. Most of these patients, I think more than 2/3 of them are high volume patients, and most of them are de novo, presenting with metastatic disease. But again, another landmark study that showed that you can do triple therapy and get benefit. It seemed to benefit patients no matter, in the subset analysis based on their disease burden, et cetera, but overall, highly significant. As we layer therapy, we're going to expect some additional side effects. Liver functions, docetaxel can impact the liver functions, abiraterone can impact the liver functions, and hypertension. Of course, you have to watch their potassium levels. So there is a little more to the monitoring during that time when they're getting their docetaxel. It's additive. There are some additive toxicities, and it has to be co-managed, in my opinion, with our medical oncology colleagues. Then a second study looking at triple therapy came out. It was a phase 3 study called Aronson's, and instead of using abiraterone, they used darolutamide. So again, ADT plus chemo was the standard. They added to that the darolutamide, and they got a significant survival benefit with the addition of the darolutamide. So it does have its current indication in the U.S. as part of that triple therapy, if you will. And the side effect profile was very well tolerated and really not much difference from the chemo ADT arm in terms of the overall side effects. So if you look at our menu here, you can see that a lot of great things have happened over the last decade plus, and we now have kind of an embarrassment of riches of good things we can do for patients that include chemotherapy, AR-targeted therapy, and in some patients we have now triple therapy. This, unfortunately, hasn't translated well to community practice, and so I need to get a more updated version, but this was a 66,000, database of patients and what they were getting as their treatment for their advanced cancer. And in this scenario, which cut off around 2021, and we were giving these courses at that time, only 25% of patients are receiving like an AR-targeted therapy. Only 10% were being offered chemo. So that isn't just urology. This is also a problem in medical oncology. So again, access to care, update, education, how are we going to get patients to have the options to receive these type of treatments? We still know that our report card is poor, and we have a lot of work to do. The last little part that I'll talk about here is the additive benefit of primary radiation in patients who present with metastatic disease. So a couple of trials were done. Actually, there's been more than a couple now, but the Stampede trial looked at randomizing patients with standard of care, and then half of them got radiation to their primary and the other half did not. And in this study, there was progression-free survival for all comers, but they didn't reach overall survival advantage for all comers based on that. But they had a kind of a plan to pre-specify about the amount of disease, just like we saw in the charted study. And in the patients who were low volume metastatic disease, there was a significant difference in their overall outcome, and it was a survival benefit. So for patients that have low volume metastatic disease in this study, there was benefit. So we didn't know that before. We always thought, well, their primary probably is quiet. It's not going to really result in anything, but there was benefit there. And so there was a second study called HORAD that also showed benefit in low volume patients. And so it's now made to the guidelines, at least in the low volume patients, that you should consider radiation to their primary after you've started their hormonal therapy treatment. The surgical role still being debated. There are small retrospective studies where they can say, oh yeah, look, we really help people. This may have made a benefit, made a difference. But from a guideline standpoint and from a evidence-based standpoint, we need higher level evidence of that. So there's a study in the United States that we're contributing to that looks at the role of either radiation or surgery in patients with metastatic disease. So until that study's finished, we really don't have the answer. But in simple terms, there are patients that are sort of chemo fit and desiring, and we will in the future be able to give even more details like, oh, there's a biomarker that says you should go chemo way. There's one that says you should go, and there's lots of people working in this space. But for Patients that do look like they're good candidates for the chemotherapy, maybe high volume, de novo, metastatic, then we certainly have triple therapy. And for the doublet therapy for those patients who are either chemo averse, not fit, or perhaps have a more lower volume situation, and then the addition of primary radiation therapy to the mix. So with that, I'll just say thank you for your attention. We're going to, if you didn't learn anything from the talk, learn that it's ADT monotherapy is not enough for most patients. And I know there's exceptions in everyone's practice where that has to be, but it probably should be in the less than 20% range. Doublet therapy is certainly an option for many men. Triple therapy, especially for high volume, newly presenting patients with metastatic disease, and primary radiation treatment for the low volume patients. So with that, I thank you for your attention, and Dr. Will Lorant's going to go up and kind of do the second part of the guidelines as our next thing. But if anybody has any questions, feel free to come up to the mic or ask. Thank you.
Thank you, Dr. Cookson. Good morning, everybody. Appreciate you all being here on the last day of the conference. So Mike showed this slide initially. Again, I just want to point out that the group of patients we're facing are those that have exhausted all local therapy options. So he talked to you about those that have biochemical recurrence but no local salvage options remaining. And then Dr. Cookson talked to us about the metastatic hormone-sensitive group. I'm now going to focus on the CRPC patients, those that are non-metastatic and those that have metastatic CRPC. Yeah, if you could put my slides on here. Let me just talk about a few definitions. Dr. Cookson kind of mentioned these, but when we talk about biochemical recurrence in men after prostatectomy, the definition we use is a PSA of 0.2 or rising. We use the Phoenix criteria for radiation failures, biochemical failures. That's nadir plus 2. When we talk about hormone-sensitive prostate cancer, that's pretty obvious. It's prostate cancer that's not been treated yet with ADT or remains sensitive to ADT. CRPC disease, well, that's defined as a rising PSA that's greater than 2 in the setting of a castrate testosterone, which is considered 50 nanograms per deciliter or less. It also can be either radiographic progression or clinical progression, despite what the PSA does. When we talk about high-volume metastatic disease, that's the charted definition. Dr. Cookson mentioned this as well. It's the presence of visceral metastasis and greater than or equal to 4 bone lesions, of which one of those needs to be outside the vertebral column or pelvis. And then if we talk about high-risk metastatic disease, that's the latitude definition, and it has a poor prognosis if patients have at least 2 of these factors. That's Gleason score 8 or higher, greater than or equal to 3 bone lesions, or visceral metastases. So I think we all know this, but 20 years ago, before the approval of docetaxel chemotherapy, urologists managed patients with advanced prostate cancer, but now it really takes a village to take care of these patients. Genetic counselors are extremely important now, and I think you'll hear more about that as we go. But it's the medical oncologist, the radiation oncologist. It's really a full team that we need to have in our practice to try and keep up with all the changes in the treatment landscape, but also to do the best job for our patients. So the 4 disease states that our advanced prostate cancer guideline handles is the biochemical recurrence without metastatic prostate cancer, hormone-sensitive metastatic prostate cancer, non-metastatic CRPC, and then metastatic CRPC. Again, Dr. Cookson covered states 1 and 2. I'm now going to focus on states 3 and 4. So let's start with the non-metastatic CRPC group. So again, in these patients, we need to perform serial PSA imaging as well as conventional imaging. The guideline recommended at least every 6 months PSA checks and at a minimum annual conventional imaging. Now, these guideline statements, we added 21 about a year and a half ago that incorporates PSMA PET. As you all know, most of us are now using PSMA PET to stage these patients rather than conventional imaging. By doing that, this group of patients has gotten smaller, right? Because PSMA PET's much better at finding the metastatic disease than conventional imaging, but we still have those patients that do fit in this category that have a negative PSMA PET, yet qualify for castration-resistant prostate cancer. So what are treatment options for this group of patients? And there are 3 FDA-approved agents, ARPIs, that can be used, and I'll go through studies with each of those. And so the guideline statement 21 says clinicians should offer apalutamide, darolutamide, or enzalutamide with continued ADT in non-metastatic CRPC patients that are at high risk for developing disease. And how they defined high risk here is they had a PSA doubling time of 10 months or less. And again, we see just similar to patients who are in the hormone-sensitive site, the PSA doubling time is a very good predictor of those that are going to fail quickly, and these trials targeted those patients. If we look at patients that have longer PSA doubling times, clinicians may recommend observation with continued ADT in these patients. And then importantly, clinicians should not offer systemic chemotherapy or immunotherapy to these patients outside the context of a clinical trial. So let's go through each of these ARPIs. What I'm going to show is a series of basically 3 phase 3 trials that showed a metastasis-free survival in each of these, and then one with longer follow-up did end up showing overall survival. So let's go through those. The first is a Spartan trial. It was over 1,200 men, and it compared apalutamide to placebo, and they showed a metastasis-free survival benefit of well over 20 months. Similar study now using darolutamide, again, over 1,500 patients, the Aramis trial, and very similar survival benefit. We're looking at about 22 months here when compared to placebo in these men with non-metastatic CRPC. The Prosper study was a trial looking at enzalutamide, again, a very similar setup, and again, a very similar metastasis-free survival benefit of north of 20 months. Importantly, with additional follow-up, there was a significant difference in overall survival, 67 months versus 56 months in this study. So these are the 3 trials that led to the FDA approval of those 3 agents in the non-metastatic CRPC space. So in summary, before we move on to disease state 4, you have 3 options to treat these men. Generally, you want to concentrate on the doubling time. Doubling time's less than 10 months. You should think about one of the agents for men with longer doubling times. An option is just to continue with monotherapy with ADT observation. Now let's move on to the metastatic CRPC space, and you'll see we've got a lot to talk about here in terms of treatment options. Obviously, baseline assessment's important. PSA, testosterone level to ensure they are at a castrate level. Very important to assess performance status, as that will influence which agents they may or may not be able to tolerate. I've listed conventional imaging. Most of us now are using PET imaging, as discussed. And then the importance of getting germline and somatic tumor testing. Now, a lot of these patients may have had germline testing. You don't need to repeat that, but certainly need to think about a targeted biopsy and being able to send the samples off for somatic tumor testing because not only will that provide prognostic information, it's going to help drive treatment decisions, and we'll talk about more of that in a minute. Just a quick slide on ECOG performance status. Obviously, patients that are in that 3 to 4 range can sometimes limit what you're able to treat them with, as long as those symptoms aren't being a direct result of their cancer. And we'll see more about that in a minute. So in terms of the AUA guidelines, in metastatic CRPC patients without PSA progression or new symptoms, clinicians should perform imaging at least annually. And I want to stop and talk about that for a minute. So we know from some of the studies that up to a quarter of patients may show progression despite having a stable PSA. So, and what I mean by that is either radiographic progression, they have enlarging lesions, or they have new lesions that show up, or they may progress from a clinical symptom standpoint. So it is important to, even if their PSA is staying relatively stable, to still think about getting annual imaging so that you could potentially find those patients that progress despite having stable PSAs. Guideline 27 is a little bit outdated at this point. We tend to stage most of these people with PSMA PET scans now. You don't have to just be considering them for one of the targeted treatments with lutetium-177. So back to germline testing. So again, if patients have not already had germline testing, we need to do it in this metastatic CRPC site. And then also we need to think about somatic testing as well, and that's to identify DNA repair deficiency, microsatellite instability, tumor mutational burden. Again, all these things give us prognostic information and also will help direct treatment for those with DNA repair deficiency mutations. We'll talk about adding PARP inhibitors in combination with some of their ADT, but super important if they've not had their genetic testing that we need to do that. I mentioned earlier, I think it's very important to involve genetic counselors because obviously there's a lot more that goes into this in terms of how these findings impact the individual patient, but also their family members. And in a busy urology clinic, I've found it's pretty hard to get into all that. And frankly, a lot of us are not trained as being genetic counselors. So we really leverage our genetic counselors to kind of take over this part and help us get the testing done, but importantly, get all the genetic counseling that goes along with it. A study Dr. Cookson showed as well, we know that DNA germline repair mutations were found in about 12% of patients with metastatic prostate cancer. That group in men with CRPC, if you look at somatic changes as well, that number can go much higher and can be a quarter of patients. The most common genes we see, BRCA2 is actually the most common, then ATM, CHEK2, BRCA1, but you see a list of ones there that I think are similar to maybe one of the questions we had initially. So since the approval of docetaxel, there have been lots of agents that are now approved in this space, and it's almost gotten hard to keep up with it. We were talking before the session started that we really need to update this guideline every year at least. But I'm going to go through each of these relatively quickly, show you the phase 3 trial that led to their approval, and then go through the rest of the guideline statements. So in men with newly diagnosed metastatic CRPC who have not received a prior ARPI, clinicians should continue traditional ADT with either abiraterone, docetaxel, or enzalutamide, and there's very high grades of evidence to support that. I'm not going to get into the mechanism a lot. I think Dr. Gerard will do that, but abiraterone is a CYP17 inhibitor. Importantly, not only does it block androgen formation in testicular tissue, it also does in adrenal tissue as well as prostate tissue. Some of the side effects, hypertension, hypokalemia, problems with glucose levels, and then obviously decreased libido. So abiraterone was approved first in the post-docetaxel state. So that's the slide, or that's the slide you see on the right there. That was the Cougar 301 study. That was published back in 2011. It then got looked at in Cougar 302 in the pre-chemo state, and again, compared to placebo, it showed an overall survival benefit, and we were looking at essentially in the 3-month range there. Let's look at enzalutamide next. It blocks the androgen receptor, and it has multiple ways that it's blocking this pathway. It blocks the binding of testosterone to the AR. It also blocks the translocation of the testosterone receptor complex into the nucleus, and then also blocks its ability to associate with DNA as well. Both apalutamide and darolutamide have a very similar mechanism. So enzalutamide was first found to be effective in the post-docetaxel state. This was the AFFIRM trial. We see about a 5-month survival benefit in enzalutamide versus placebo in men that had already been treated with docetaxel chemotherapy and had progressed. It then moved back in a similar fashion in the PREVAIL trial to the pre-chemo state, and you see about a 2.5-month overall survival benefit in those patients. So the first study was 2012, the second one, the PREVAIL study, was 2014. What about docetaxel? Well, this was the first study showing that chemotherapy could be effective, really effective in treating these patients. It was compared against mitoxantrone, and this was basically we see about a 3-month survival benefit in men treated with docetaxel versus those treated with mitoxantrone. This was the TAX 327 study and became standard for men with CRPC, and now that's been almost 2 decades ago. So let's move on to some other options. In men with metastatic CRPC who are asymptomatic or very minimally symptomatic, you may offer Sipuleucel-T. That's an immunotherapy, and again, it's important that these men are not symptomatic. And what we saw in the IMPACT trial is about a 4-month overall survival benefit in men that were treated with this immunotherapy. Clinicians should offer radium-223 in patients with symptoms from bony metastasis that do not have any known visceral disease and have no lymphadenopathy greater than 3 centimeters. So if they have visceral disease or they have really bulky lymphadenopathy, radium-223 is not an option, but for men with symptoms and primarily bony metastasis, radium-223 is an important treatment option for these men. And what I've highlighted here is both the pre-docetaxel state and the post-docetaxel state, and what you see is a significant survival benefit in both of those groups of about 4 to 5 months. That was the IMPACT study. Moving on to what we would consider second-line chemotherapy. So in men with metastatic CRPC who receive prior docetaxel chemotherapy with or without abiraterone or enzalutamide, clinicians may offer cabazitaxel. And in those who have received docetaxel and abiraterone or enzalutamide, clinicians should recommend cabazitaxel rather than moving to a second androgen receptor pathway inhibitor. The TROPIC study looked at cabazitaxel in the second line and showed a 15 to 12.7 month survival benefit of cabazitaxel when compared to mitoxantrone. So let's talk about the PARP inhibitors for just a second. So we've already discussed the importance of genetic testing. And so in men who are found to have a germline or somatic homologous recombination repair mutation that have had prior treatment with enzalutamide or abiraterone or docetaxel, they should be offered a PARP inhibitor. And there are right now 4 different PARP inhibitors that are options for treatment of these patients with HRR mutations, and Dr. Keibel is going to go into more detail about those. If you cannot access a PARP inhibitor for these patients, platinum-based chemotherapy is an option as well. And then for those patients that have microsatellite instability high levels, pembrolizumab is an option as well. So let's first look at the PROfound study, which looked at olaparib, and it showed a 7.4-month progression-free survival benefit compared to 3.6 in patients that had a homologous recombination repair mutation. Next study is a Triton-3 study that looked at recuperab, and it also showed basically improvement whether it was compared to docetaxel in the control arm or whether it was compared to a second-generation ARPI. You saw a very significant progression-free survival benefit. So let's move on to one of the newer treatments, which is the lutetium-177 or Pluvicto. It should be offered to patients with progressive metastatic CRPC who have previously received docetaxel and an androgen pathway inhibitor with a positive PSMA PET lesion. The first study, and again, this is looking at patients who have already received docetaxel chemotherapy, was the VISION trial, and it showed an overall survival benefit in patients who received lutetium-177 versus standard of care. It was well tolerated, and again, these patients have to have predominant PSMA positive disease, and it was first approved again in the post-docetaxel state. Also saw a significant progression-free survival benefit, first symptomatic skeletal event, an improvement there. It was then tested in the pre-chemotherapy state, the PSMA-4 trial, and again, it showed a radiographic progression-free survival in the lutetium-177 group of 11.6 months versus 5.6 months, and has just recently been approved by the FDA for treatment of men with metastatic CRPC in the pre-chemotherapy space. So with that, I'll hand things over to, I think, Dr. Gerard, you're going to go next. Thank you for your attention.
Let's see, could you pull up the other talk of mine? Yes. Okay, well, thanks. So we're going to dig a little deeper into some of the application of these agents, side effects. Certainly, it's been a remarkable shift in the management of disease due to these new androgen receptor pathway inhibitors. And it's important for us as urologists to know about the indications as well as their side effects and usage. And we'll also spend some time talking about treatment sequencing. So let's start with a case here. This is an 80-year-old with metastatic castration-resistant prostate cancer, had a history of biochemical recurrence following radiation, was actually placed on androgen deprivation for a number of years. His PSA began rising, and you can see over the last 12 months it began increasing very rapidly. Testosterone was checked and noted to be low, as expected, and there were 2 bony metastases that were seen with enlarged pelvic and retroperitoneal lymph nodes. This patient was asymptomatic. So really, what are the options for this low-volume M1 castration-resistant prostate cancer? Again, this is looking at the current therapeutic landscape, and a lot of these androgen receptor pathway inhibitors were initially applied later in the disease, as you've heard, in metastatic castration-resistant prostate cancer, but now we're using them more commonly earlier in the disease. And again, it's important for us to be aware of their use, side effects, and contraindications. So we're going to spend a moment talking about the mechanisms of castration-resistant prostate cancer development. Again, it's important to understand these existing and new applications, the mechanisms and side effects, and then we'll spend a little time talking about some of the potential managing some of the symptoms associated with androgen deprivation therapy and more intense therapy. So it was really a striking finding, and this wasn't that long ago, that over 70% of castration-resistant prostate cancer metastases exhibited robust androgen receptor expression. What you see on the left side of your screen is a metastatic tumor, a lymph node, and you can see the brown staining, which is robust androgen receptor expression. And indeed, the androgen receptor is an oncogene. It's amplified in men with castration-resistant disease. So when we think about the mechanisms for the development of castration resistance, realize that there are a number of ligand-independent mechanisms that don't necessarily involve the androgen receptor, but what we're going to plan to focus on here is the androgen receptor ligand-dependent mechanisms. What you can see in the center there is actually amplification of the androgen receptor that occurs. Again, this takes advantage of lower levels of androgens floating around to lead to increased signaling. What you can see in the upper right is the development or the use of adrenal androgens Again, through various pathways that we'll talk about, these can form DHEA and also stimulate and bind to the androgen receptor. Again, abiraterone targets this mechanism. On the left is an increased use of the other types of glucocorticoids and other androgens, non-androgens that are available. There are various point mutations that actually occur in the androgen receptor. And again, this allows it to use progesterone, hydrocortisol, estradiol, and other types of AR antagonists that can lead to increased promiscuity and signaling through the androgen receptor. And then finally on the right, there is androgen receptor variants that develop. And one of these that's important is the ARV7, which is probably the best known. And again, these things can signal independently without the presence of androgen. So many of our newer agents, apalutamide, darolutamide, and enzalutamide, all prevent binding of these various types of androgens to the receptor. Now, we saw this slide, and remember that abiraterone is an irreversible inhibitor of the hydroxylase and lyase activities of CYP17. Again, this catalyzes the conversion of C21 progesterone precursors to C19. So again, and this is much more potent than ketoconazole, which is something that we used early in my career. And abiraterone is associated with expected increases in mineralocorticoids that are upstream of CYP17A, and this accounts for a lot of the potentially treatment-related side effects. You get salt retention, hypertension, low potassium. It's also associated with other potential side effects, which are again modulated by giving prednisone, which is routinely done with the use of abiraterone. We've seen these studies, post-chemotherapy use of abiraterone. Let's just take a look at some of the potential side effects associated with this trial. And what you can see here is that many of these patients developed liver function abnormalities. So it's important in these patients to monitor ALT, AST in these individuals. You can also see the hypokalemia that develops commonly, fluid retention, there are cardiac disorders that arise as well. So it's important for us to work with our primary care physicians to help monitor these patients. How do we minimize some of the side effects of abiraterone? Taking them on an empty stomach. Obviously, we give this with prednisone, and there are some side effects associated with the use of that. Initiating these agents, liver function tests and electrolytes need to be checked at 2 weeks and then routinely thereafter. And if you do run into a situation where liver function tests are elevated, you need to hold abiraterone until they normalize and then restart at a lower dose. And as I mentioned, routine assessments for hypertension and fluid retention. And remember, there are some drug interactions that can occur. Coumadin actually will increase the level of these. And these, again, these CYP inhibitors can alter the metabolism of this agent. So let's shift to another case here. This is in this 80-year-old with low volume metastatic castration-resistant prostate cancer. Options would include for this patient the continued androgen deprivation therapy with abiraterone plus prednisone, or docetaxel or enzalutamide. And again, this patient is asymptomatic, so Ciplicil-T might be an option to consider as well, especially given how little disease he had. So when we think about shifting this forward into the metastatic hormone-sensitive prostate cancer setting, again, remember there are a number of options for these patients that we have. This was mentioned looking at the Latitude trial. Again, hypertension and liver function issues were ones that arose in these patients with abiraterone, so those need to be monitored. So when we think about our patients and who might be a good candidate for abiraterone, It is FDA approved before metastatic castration-resistant prostate cancer, before and after chemotherapy, and then also in this metastatic hormone-sensitive space. Remember, hypertension, hypokalemia, edema. You can also get steroid-induced hyperglycemia. So patients that are generally poor candidates are, again, those that can't tolerate the systemic steroids, brittle diabetics, individuals with gastric ulcers or rapidly progressive disease, active infections, are probably not ideal patients for these types of drugs. Patients with a significant cardiac disease, and then finally, viral hepatitis, alcoholics, other hepatic dysfunction. So we've talked a little bit about the use of abiraterone. Let's shift gears and talk about some of these other androgen receptor pathway inhibitors. So here's another case. It's a 60-year-old with a new diagnosis of metastatic prostate cancer, high volume. And you can see in the PET scan to your right the number of metastatic lesions. He had bone pain and fatigue. PSA was 120, and it was a grade group 5 cancer that was found on biopsy. Again, was fairly symptomatic related to this. So you saw briefly this and realized that enzalutamide was a rationally designed androgen receptor inhibitor. It's often termed a second-generation non-steroidal anti-androgen. It has greatly increased efficacy with 5 to 8-fold higher affinity as an anti-androgen. It inhibits the binding of the androgens to the androgen receptor. It also inhibits nuclear translocation of the androgen receptor, and then also its association of the androgen receptor with DNA. So it really impacts multiple steps along that pathway. Apalutamide and darolutamide have similar mechanisms of action. We can talk about how they slightly differ between the three. So again, enzalutamide is utilized in pre and post docetaxel chemotherapy. Let's focus on some of the side effects that are associated with enzalutamide. And there's several we need to emphasize here. One is it's often associated with fatigue, and enzalutamide appears to have more central nervous system penetration. So in our elderly patients that have a performance status, again, it's an agent that can sometimes worsen this. Hot flashes are common with many of these agents. There was a slightly increased risk of seizures associated with this. And one thing that was especially notable, hypertension, but these falls in these patients. So again, in our elderly patients, we want to be careful applying this medication. So how do you minimize and manage the side effects associated with enzalutamide? You can dose reduce enzalutamide from 160 to 80 milligrams, and especially when you're using them with other CYP2C8 inhibitors. One of these is gemfibrozol. Again, this is a statin. Enzalutamide can also affect other CYP-inducing agents such as warfarin. Again, you need to use care when giving with those drugs. If there is profound fatigue, consider a dose reduction. Also be careful with other CNS acting agents. It can lower the seizure threshold. And remember, enzalutamide has a fairly long half-life of 8 to 9 days. So if you do run into a situation where the patient's very fatigued, you implement a dose hold. Its half-life is about 8 to 9 days. So who might we want apply or consider optimal for these patients? Again, individuals with metastatic cancer or metastatic hormone-sensitive prostate cancer. Remember the side effects. We talked about the fatigue, hypertension. Actually, GI upset is another aspect of usage of these. CNS-related side effects, seizures, and there's something also, posterior reversible encephalopathy syndrome that can arise. So patients that are poor candidates for these types of agents, history of seizures, strokes, and falls, patients who already have a lot of fatigue and advanced age. So apalutamide has a similar mechanism of action and similar side effects as enzalutamide. But remember, a subset of these patients will also develop hypothyroidism, so you need to follow their thyroid levels, and a significant rash in about 15 to 20% of these patients as well, a grade 3 rash. It can be very bothersome. Darolutamide, there may be less penetration of the blood-brain barrier, so theoretically potentially some less fatigue, seizures, and hypertension with this agent. So let's talk about sequencing here a moment. So which of these androgen signaling inhibitors should go first in advanced disease? And there's really limited data, head-to-head data. I'm going to talk a moment about this, but certainly often financial toxicity is important, which agent is available, and obviously the clinical situation should dictate. When we're thinking about sequencing of these drugs, generally if they fail, either one of these agents, consider moving to a different mechanism rather than just following them with another androgen receptor pathway inhibitor. And there are unique situations where a patient may present with very rapid disease progression, significant symptoms, visceral disease, liver metastases. Again, we may want to consider moving on to platinum-based chemotherapy in those individuals. So this was a study that was presented 3 months ago at GU ASCO, and it really looked at a meta-analysis of all the current available drugs, current available trials, phase 3 trials using these androgen signaling inhibitors. This is about 8,000 patients. And what they showed is, not surprisingly, if you combine androgen signaling inhibitors and androgen deprivation therapy together, they improve survival compared to ADT alone. There were really no differences between enzalutamide, apalutamide, all of these agents when we looked at responses, so they're all equally effective. But one of the striking aspects about this study was there appeared to be decreased overall survival with abiraterone in this oldest age group. And the reason this is important, I mentioned to you that sometimes they tolerate abiraterone better than enzalutamide just because of it doesn't quite have the fatigue and other issues associated with this. So I think there are many certainly medical oncologists who are struggling with this data a little bit, but it's important for you all to be aware of this as well. So as far as triplet therapy, what are the kinds of patients that we might want to apply for this, and what are the side effects that are associated with this? So as mentioned, there have been 2 triplet therapy trials that have been found. The first was the Arisons trial, and it's important that this therapy is generally utilized for high-volume de novo metastatic disease. So when we think about adding additional medications together, this is really the group you want to target. The risk of death was reduced by about 32% when you combine darolutamide, docetaxel, and androgen deprivation therapy. And the toxicity was similar, although by adding this androgen signaling inhibitor, the fatigue was somewhat worse. Again, the PEACE-1 trial was a similar design using abiraterone that showed a benefit as well. Also, it's important when these patients are getting chemotherapy to monitor for neutropenia. And again, the side effects were fairly similar between the triplet and doublet therapy. So for this 60-year-old with a new diagnosis of metastatic high-volume cancer, again, it's de novo. So that could either be offered doublet or triplet therapy, and that's indeed what this patient got. So let's just spend a moment here talking a little bit about some of the side effects associated with androgen deprivation therapy. And certainly with regard to hot flashes, they're very common. In severe situations, you can use venlafaxine or gabapentin in these patients. Obviously, they all need to be monitored for osteoporosis, and certainly in our guidelines, we have a number of statements regarding this. We talked a little bit about the fatigue. Regular exercise can sometimes minimize the fatigue, and we encourage our patients on these medications to certainly undertake this. Metabolic syndrome is something that is associated with longer-term androgen deprivation therapy. And we'll talk a little bit more about one of these that's generated a lot of interest in the press, and that's some of the increased cardiovascular risk associated with long-term androgen deprivation therapy. And it was back in 2010 that the FDA added new safety information regarding longer-term use of these GnRH agonists. Again, warning of the increased risk of diabetes and other certain cardiovascular issues such as heart attack, stroke, sudden cardiac death. So it's important when we're starting patients and monitoring our patients on these agents to recommend routine assessment of cardiovascular risk factors, blood pressure, lipids, keeping an eye on the glucose. One question that's arisen is, are these GnRH agonists like leuprolide, are they comparable to antagonists such as degarelix? But in a trial that was really designed to ask this question, there was really no major difference in cardiovascular mortality associated with both of these agents. But I do think we all have some certainly concerns about androgen receptor long-term treatment and treatment intensification. And certainly as I think we move forward, de-intensification is going to become a theme that we're increasingly involved with. So for this section, some of the take-home points, combining these androgen deprivation therapy and androgen signaling inhibitors are standard of care in metastatic hormone-sensitive therapy. Again, patients, enzalutamide, apalutamide, darolutamide, these are those patients that can't really tolerate systemic steroids, brittle diabetics, gastric ulcer. Abiraterone is an androgen synthesis inhibitor, and again, it's preferred in patients with seizure history, severe baseline fatigue, may be better tolerated in some of our older patients. We talked a little bit about triplet therapy and its importance in de novo disease. And then the side effects are important to treat and monitor in these patients. Okay, so if we can move up to the next, move up to number 4 there. So we'll just spend a couple of minutes here talking about chemotherapy. And certainly as the application of chemotherapy is being used earlier in the disease, and as such, we should be familiar with its uses and obviously side effects. So this is just looking at chemotherapies being given in hormone-sensitive prostate cancer at this point. You can see in the other red boxes to the side, obviously, castration-resistant disease. Cabazitaxel, we'll talk a little bit about that, some of the side effects associated with it. And then we'll end up mentioning some of the other more comorbidities of concern with these agents and some of our newer drugs. So again, this is a 60-year-old with a high-volume metastatic disease. What other options do we have for this patient? And we talked about triplet therapy as being an option. So, but it is reasonable depending on what is available in your neighborhood. And I know a number of individuals in this meeting are from other countries. Docetaxel still is used as a doublet therapy in this kind of patient. One nice thing about it is it's only given for a shorter period of time. Abiraterone, apalutamide, and enzalutamide are other options. And we talked a little bit about the increasing incidence of metastatic disease now that we're seeing in our patient clinics. So with regard to mechanism of action of these drugs such as docetaxel and cabazitaxel, again, remember it binds to tubulin and promotes which promotes microtubule assembly. It actually inhibits this. And so it's really disrupting these cells that are turning over. And so it's really a basic anti-neoplastic agent. So we talked a little bit about the CHARTED trial, which was really remarkable in that it demonstrated about a 15-month improvement in survival in metastatic hormone-sensitive prostate cancer. Now, what kinds of increased side effects does the administration of docetaxel provide, and how is it given? So it is an IV infusion at 75 milligrams per meter squared once every 3 weeks, and it's generally given for 6 months. When you're giving it with androgen deprivation therapy, there's no need for concurrent prednisone. Dose reductions are permissible. And disease evaluation is usually consists of a PSA every 3 weeks, and then either imaging of some sort. If at baseline, then obviously if there's any development of clinical progression. Some of the major toxicities associated with this include febrile neutropenia in about 6%, fatigue in 4%, diarrhea. Stomatitis can actually be fairly significant. In addition, patients can develop a dry eye syndrome. And another aspect is obviously a neuropathy that can develop in a subset of these patients. We talked a little bit about this issue of disease stratification and how we've used the CHARTED criteria previously, with which essentially high-volume disease is defined as the presence of at least 4 bone lesions. But obviously that's changed a lot with the development of advanced imaging with PSMA PET imaging. And on the right, I just wanted to point out here that really the major way that PET imaging is altering the types of patients we see is really in this situation of N1 disease. So when you have a patient who comes in, some enlarged lymph nodes by CT scan in the pelvis, what we're essentially finding is that there are more lymph nodes above the common iliacs. And so really the largest increase in staging change that we've seen with PSMA PET is in this M1A disease. So we've talked a little bit about triplet therapy. The side effects are fairly comparable between doublet and triplet therapy, although the fatigue was worse with darolutamide. And these patients otherwise tolerated this fairly well. So how do we really choose between docetaxel, an androgen pathway inhibitor, or triplet therapy? And as I mentioned, the studies that have looked at really the benefit of triplet therapy is in these de novo high-volume patients, like the one I just showed you, or patients that are rapidly progressing through darolutamide or abiraterone. And it is important to avoid overtreatment in these patients. Not every patient should be on triplet therapy. There's really no data to suggest that it benefits certainly patients with, for example, in a biochemical recurrence space. The approach will also vary based on cost, side effects, comorbidities. Docetaxel, we talked a little bit about that. 6 cycles. One nice thing about it is you do 6 cycles and then you're done, versus these androgen receptor pathway inhibitors, which one has to continue along over time. And we've talked about some of the monitoring that one needs with those agents. So let's talk about another case here. This is a patient with metastatic castration-resistant prostate cancer who's really having a rapid recurrence of his disease. Otherwise, 63 years old, history of Gleason 9 cancer, treated with radiation, but the PSA really began rising rapidly after treatment. And doubling time of 3 months. Now he's presenting with new pain, multiple osteoblastic lesions of the spine, a new liver lesion, and a PSA of 56. So for this individual who has failed essentially an androgen signaling inhibitor, what are our treatment options? And I do think these NCCN guidelines are useful for helping us categorize our patients. Again, this patient has received prior novel hormone therapy, no previous chemotherapy. So moving on to chemotherapy would be important for this patient. Another option would be to consider cabazitaxel. He has rapidly progressive disease, So that might consider carboplatin, especially if on biopsy it was more undifferentiated. Because of the liver disease, radium wouldn't be a good option. We'd want to do genetic testing. Does it consider if there are any other options we have as far as targeted therapy? Cipocil CT would not be a good option in this patient. He's symptomatic. So when we think about the general principles of how we choose treatments for patients, in general, we would want to consider a novel mechanism of action. This patient failed abiraterone. Enzalutamide is probably not going to help much. Also, what options are available at the current practice location? Visceral metastases are important. Generally, they portend a worse outcome in these patients. And, is this patient a candidate for chemotherapy? And we'll talk a little bit about trying to optimize and evaluate those patients. So we talked about docetaxel, which was really the first drug to improve overall survival about 20 years ago. And some of the comorbidities we need to think about with this drug include performance status, and that is often a limiting factor in delivering chemotherapy in this population. These patients can develop congestive heart failure or volume overload due to third spacing from docetaxel. Peripheral neuropathy is an issue that arises. Liver function tests have to be monitored. And because of some of the fluid issues that arise with docetaxel, you have to be concerned about arrhythmias in patients with a history of coronary artery disease. Often these patients will receive dexamethasone, which can create issues in brittle diabetics. So when we're assessing our patients for chemotherapy, this is actually a very useful chemotherapy fitness chart, and it predicts toxicity. On the right, actually, of this is looking at just more of an ECOG performance status, and you can see there's really no big benefit as far as trying to identify those patients that might have increased toxicity. But on the left is looking at these predictors, and they include, you can read them here, advanced age, previous chemotherapy, hemoglobin, creatinine, activity levels. All of these, a number of points are given for this, and then it can help you predict whether this individual, what their side effect profile might be giving chemotherapy. So again, who's the ideal patient for metastatic castration-resistant prostate cancer? Symptomatic disease, bone or visceral disease, rapidly progressive, confirmed adenocarcinoma, and generally it's used after or with a second-generation androgen pathway inhibitor. So I'll just mention briefly cabazitaxel, and this was really an agent that was developed. Again, it's a microtubular inhibitor. It was developed for docetaxel failures. And rationally, it doesn't necessarily make that much sense to take a microtubular inhibitor and then follow it with another one. But the number of studies have shown to benefit here. I would say in this modern era, it's probably being used less, given some of the other options we now have. But there are 4 trials surrounding this. The TROPIC trial, which basically led to its approval post-docetaxel. The CARD trial, which demonstrated, again, an advantage to using this post-androgen receptor signaling inhibitor versus following it with another ARSI. The Prostate trial, which demonstrated you can use lower dosing, decreasing side effects associated with this. And then the Firstana trial, where basically you were substituting cabazitaxel as first-line chemo. And one thing I was just going to point out about this trial, I mean, this is not a home run. I mean, these are 2 or 3 month improvements in survival. So again, this drug is approved for docetaxel failures. All patients require prophylactic growth factors. It is an option for initial chemotherapy after androgen receptor signaling inhibitor failure. Some patients do tolerate this better than docetaxel, as the side effect profile is slightly different. And on the right, monitoring many of the things we've talked about that also occur with docetaxel. So what about in these patients as their disease progresses? An important thing to be cognizant of is is there neuroendocrine differentiation in these patients? So again, looking at our guidelines, in a patient who's failed chemotherapy or prior novel hormone therapy, often these patients will move forward with lutetium if they are a candidate for this. But other treatment options would be to consider cabazitaxel, docetaxel rechallenge. Another option is if this patient begins to develop neuroendocrine disease, carboplatin-based or platinum-based chemotherapy is an option to think about. And I just wanted to emphasize this issue. There's been a lot more discussion and interest in developing treatments for variant castration-resistant prostate cancer. Again, situations where one should think about this are a lot of visceral lesions, especially liver metastases, extremely bulky lymph nodes. This is in the setting of a low PSA and sometimes primarily lytic rather than blastic bone metastases. They also develop some of these neuroendocrine markers. So molecular testing of the biopsy tissue is important just to determine whether this is an adenocarcinoma. And what you can see on the right here, this is a patient from several years ago. They developed a rising PSA, were placed on abiraterone. The PSA actually just continued to rise. They were then started on docetaxel. The PSA decreased slightly, but they began to develop increased fatigue and bone pain. Imaging was repeated, and they were found to have a lot of liver lesions at that point with bony and lymph node metastases. And indeed, this patient had developed a small cell variant, and they were treated with actually carboplatin and etoposide. Ended up not responding that well to this. So there's a lot of interest in looking at the molecular taxonomy of these variant castration-resistant prostate cancer. This is a most recent variation of how to categorize these patients by Michael Hafner. And what you can see here is these patients, these generally will arise after AR-targeted therapy, although in a subset of patients, they'll be found in primary disease. He's proposing to categorize these into 4 subsets. Again, androgen receptor positive, neuroendocrine negative, which is, again, more of our adenocarcinoma variant. But then you can see AR negative, neuroendocrine positive, small cell. There are other poorly differentiated ones that may be AR negative and neuroendocrine negative. So there are a lot of different variations to be aware of. Genomics may help us identify these patients, and but the key here is the fact that it is PSA secretion. They lack PSA secretion. So Dr. Keibel is going to be moving forward here, talking about biomarkers in advanced chemotherapy treatment. And I'll wrap up here just by mentioning the fact that there are a number of chemotherapy agents for these patients. We talked a little bit about docetaxel and cabazitaxel. Performance status should really help guide appropriate treatment for these patients. And we'll hear a bit more about PARP inhibitors and some of these new biomarkers. Good. Thank you.
Okay, so it's one of my slides. So it'll be heavily redacted. I promise I will get everybody out of here at 9:30. If I miss anything, I apologize because I had a lot of stuff to cover. So we'll start off by talking about bone health, which is incredibly important for patients with prostate cancer. Do I click this to advance the slide? There we go. Okay, so this is clearly, clinically relevant. The issue of bone loss is a problem with elderly men, period. Okay, and ADT is associated with the loss of bone mineral density. I think we all realize that, so we have to be acutely aware of it. think what's interesting, this is the U.S. Preventive Task Force is always going after us about, PSA screening. Well, they've gone after osteoporosis prevention, which I think is really interesting. I underlined it here, which says that it doesn't even recommend it anymore for elderly men, which I think is a critical issue for us because we're used to our patients being on vitamin D and calcium when they come in to see us, and increasingly they won't be on that. So we need to be acutely aware of that. These are some of the risk factors. I think they're really knowledgeable for all of these. Bottom line is some of these we can't control, right? Like a previous fracture, but some of them, like excessive alcohol use and smoking and weight loss, we can try and get our patients to do a better job around that. It is clearly a dose-response relationship with the use of hormone therapy. Can I ask a favor, sir? Can I make this screen a little bigger? It's kind of really small. So what you can see here is as patients are put on hormone therapy for longer periods of time, there's an increased risk of fracture that increases, okay? And the overall survival is affected by men having fractures. I mean, if you have a fracture, you're much more likely to die, okay, than if you don't have a fracture. So we need to take steps to prevent patients from having fractures. The NCCN guidelines I have up here, basically showing that DEXA scan is recommended for patients as a baseline, and then repeated about every 1 to 2 years, depending on a FRAX. Now I'm going to go through what the FRAX is in a second, and then you repeat the DEXA about once a year. Once they're on resorptive therapy. So when they're on androgen deprivation, you need to do about once every 2 years, just get a baseline, and then and see whether they're losing bone while they're on hormone therapy. And then once they're on resorptive therapy, then you need to repeat it every year. And really, other organizations have essentially, including our own, has essentially the same recommendations. If there's one thing you're going to write down from my talk, at least, it should be the FRAX the website. Essentially, it's a calculator that gives you the risk of whether somebody is going to have a fracture within the next 10 years, and you use that in order to decide whether somebody should be put on resorptive therapy. So baseline test, as I said, was to get a DEXA scan. I have the definitions of osteopenia and osteoporosis up here. If they're in those bad ranges, we're going to talk about what to do about that. You want to get blood tests, including calcium, creatinine, and vitamin D. And then, as I stated earlier, you really should emphasize to the patients that they should stop smoking, they should not drink a lot, and they should do weight-bearing exercise in order to maintain and increase the strength of their bones. Vitamin D and calcium, there's no specific definition that's in the AUA guidelines, but the bone health organizations generally recommend calcium about 1,000 milligrams daily between 50 and 70, and then calcium about 1,200 if you're greater than 70, and then vitamin D3, roughly 800 to 1,000 international units a day. I think basically everybody should be on vitamin D once they reach a certain age. I certainly am. What about calcium? Well, calcium is also important to prevent bone mineral loss, but there's conflicting data on whether it increases the risk of fatal calcium. I think it's particularly important. You're going to put people on resorptive therapy. By that I mean Zometa and denosumab. You need to put patients on calcium because of that, because there's profound hypocalcemia associated with these drugs. We'll go through that as well. It's better absorbed in divided doses than with meals. So taking a pill on an empty stomach, now you want to take it like maybe with breakfast and with dinner. And calcium citrate appears to absorb better than calcium carbonate. So what's the role for bone-modifying agents? Can I have my phone so I can just keep track of the time? I mean, the concept of taking one of these is that you're going to increase the bone mineral density, and therefore you're going to decrease your fracture risk. And these are some of the agents that you can actually use. So this is zoledronic acid. I think pretty much everybody in the room is familiar with this. This is not the dose for people. This is it's given as an IV infusion. It decreases skeletal-related events compared to placebo, and the toxicity is fairly significant, which you need to be aware of. Osteonecrosis of the jaw, we're going to go over that in detail. Hypoglycemia, nephrotoxicity. This is not a drug you want to give, or you have to change the dose of the drug if someone's got a decrease in calcium, in their kidney function, and it can cause some flu-like symptoms. This is just a nice meta-analysis that was published recently that shows that for all these different drugs, there's a decrease or an improvement in the lumbar bone mineral density, an improvement in the femoral neck bone mineral density, and an increase in the hip. So zoledronic acid, one of the key things about this is that you need to calculate the dose if the person is got some renal failure, and you don't want to just go ahead and give the same dose because it'll be bad for the patient. Denosumab, you don't have to worry about the dose. It can be the same dose for all patients. It's given sub-Q once every 4 weeks. It has the same toxicity of osteonecrosis and hypocalcemia as denosumab, as zoledronic acid. I think it actually probably has a slightly higher risk, and I'm going to go a little bit of data of that, probably because it's a more effective drug. So osteonecrosis of the jaw is clearly, this is some nice pictures of that, clearly a huge issue. It's really important that if they have any dental issues, you take care of it before they're put on any of these agents, not after. You want to emphasize that their dentures need to fit correctly. They need to have regular visits to the dentist. This is something that once it occurs is really hard to manage. Again, just for time, these are the risk factors. And as I just went through, these are the ways that you minimize it. You really need to just pay attention to dental health. If it develops, they can do things like go ahead and do some debridement, put on a graft. You need a good oral surgeon. This isn't something that should be managed by a dentist. Bottom line is the best way to stop this from happening is to avoid it. So which is better? So there's a nice randomized trial of patients that had metastatic castrate-resistant prostate cancer, and the take-home message is that there's no difference in overall survival or time to progression, but there is a better bone mineral density with the denosumab. Denosumab versus the trial results, as I said, the hypocalcemia and the osteonecrosis of the jaw seems to be a little bit worse with the denosumab. I think that's just because it's a slightly stronger drug. A special note, one of the problems with denosumab is once you stop it, the bone rapidly reverts to where it was before. So one of the tricks that has been highlighted to me is when you take someone off of denosumab, give them a capping dose of zoledronic acid. It's not FDA approved, but the idea of this is that it holds the bone where it actually is. So you don't have to worry. I mean, the key thing to worry about is you stop the drug and all of a sudden they've lost a lot of bone mineral density. I think it's really critical to decrease fractures because of the problems with mortality. This is a rather nice study where they looked at roughly, I'm sorry, I'm a slide behind. I apologize about that. The screen here is a little different than the screen down there. So this is a study looking at 54,000 patients getting SEER data. They were started on ADT, and what you find is, and you want to see if it decreased mortality. The bottom line is it did. The patients that received DEXA screening were more likely to be put on drugs which decreased their fracture rate. The patients that got DEXA screening were less likely to more likely to be put on bone modifying agents. The DEXA screen was associated with a decreased risk of fracture, and the 5-year overall survival was better in those patients. So the bottom line is follow the algorithm. If you follow the algorithm, they'll be less likely to have fractures, and they'll be more likely to be put on the agents that help prevent fractures, and they'll be less likely to die. So it's clearly a win. So this is the recommendations. Basically, the key thing is to assess the risk. Go ahead and put them on supplemental vitamin D, smoking cessation. Start bisphosphonate or denosumab if needed, and go ahead and put them on prescribe the bone saving agents. I'm going to skip this. This is just because we only have so much time. The next thing is to talk about targeting the bone with radiation, which I think is an important concept. So this is a STOMP trial. This is a trial, small trial, only 62 patients, but they were going ahead and given targeted radiation to the metastatic deposits versus surgery versus just surveillance. The endpoint, importantly, was not whether they were alive or dead. It's whether they stayed off of androgen deprivation therapy, and they did. Okay? Oriole trial, a very similar trial, but in this trial, the patients could have had PET scans, and this was, again, targeted. And what, again, you found is that the progression was less in the patients to androgen deprivation therapy if you went ahead and you radiated the MET. Again, I apologize. I just want to make sure we get through all of this information. The Extend trial is the third trial, which showed essentially the same thing. So the bottom line with all these trials is you want to go ahead and give radiation therapy to these low-volume METs. I mean, you don't want to do it when the patient's whole body is littered with METs, because what will end up happening is you'll depress their bone marrow and you're not going to keep them off androgen deprivation. But if a patient has a few METs, you go ahead and you radiate them, you will keep them off androgen deprivation for a longer period of time. So what about radiopharmaceuticals? These also are attacking the bone. So radium-223 it mimics calcium, and by doing that, it gets tracked to the bone. It goes ahead and emits an alpha particle, which does not have a very deep depth of penetration, so it does not cause a lot of depression of the bone marrow. This is a nice little diagram of this. It basically shows that the radiation does not presumably affect the marrow as much as other forms of therapy. This was approved with the ASIMCA trial, a randomized trial in patients that had symptomatic, I want to emphasize that again, symptomatic castrate-resistant prostate cancer and no known visceral metastases. Really important, okay? So if they have visceral metastases, this is not the right treatment for them, okay? And it clearly improved overall survival on this Kaplan-Meier curve, okay? And it also, interestingly, decreased their rate of having a skeletal-related event, which I think makes sense. I mean, if you go ahead and you kill the bone met, much less likely to lead to a fracture. So I think this is a really good agent that we don't really use that much. Now, people have gotten the really bright idea of, well, if we can't treat the visceral, why don't we treat the visceral with abiraterone and we'll treat the bone mets with the radium-223. This is a rather nice trial, which again showed that unfortunately the side effects, bone fragility, even overall survival was worse in the patients that got the combination therapy. So when you hear about trials like the PEACE trial where they combined, triple therapy and it improved overall survival, that's a win, but it was proven. So we need to do studies in this kind of space where we prove that by adding more agents, we actually improve their outcome, because sometimes more agents just increase the toxicity and therefore decrease the survival. Lutetium is an important treatment that all of you should know about. This is a PSMA-targeted agent. So what this does is you go ahead and give the patient a drug that then flows to the cancer cell, breaks the DNA through radiation, and kills the patient. So the first study is the VISION trial. VISION trial has about 1,100 patients. Patients had castrate-resistant prostate cancer and a positive PSMA PET. And it was a 2-to-1 randomization where patients got lutetium and standard of care versus standard of care. And what they found, which was presented very nicely by Dr. Lorenz, is that there was an improvement in survival associated with this. There's another trial called Therapy, a very similar trial, which compared lutetium to carbazitaxel, okay? And I'm going to have trouble reading this with the size of the screen up here, but essentially what you see is that thank you very much. Progression-free survival was better in the patients that got lutetium, but when you looked at overall survival, there was really no difference between the two. So, I think lutetium is probably tolerated better than carbazitaxel, but you have to weigh these costs and benefits as you compare all of these agents. This was a study called the PSMA-4 trial. Patients were put on a different agent, but it had the same concept and it was targeting PSMA. These were patients who had been previously treated in a castrate-resistant state with a positive PSMA with a prior novel androgen receptor inhibitor. Basically, it was change the drug. So if they were on ABI, you put them on ENZA. If they were on ENZA, you put them on ABI. You just change the drug versus getting the lutetium. And I don't think we're that surprised that the radiographic progression-free survival was better in the lutetium trial, okay? Because basically we found that patients don't do very well now when we just change their agent. But interestingly, the overall survival didn't really show a benefit between the two. And I think this probably reflects the fact that we have a lot of really good agents now. And so these patients, when they failed, got a different agent. And the end result may be a PARP inhibitor, maybe, I don't know, but it definitely improved their outcome. Okay, this is the ENZA-P trial. This is a randomized trial in patients who have castrate-resistant prostate cancer and rising PSA who have not seen prior ARI, and they were given enzalutamide versus enzalutamide plus lutetium. And I don't think we're surprised to see the enzalutamide plus lutetium arm did better from an overall survival standpoint. Again, showing that combination therapy, before I showed that a combination of radium-223 plus abiraterone actually was worse. In this case, a combination of lutetium plus enzalutamide was better, and it may be because of the side effects of the treatment. So this is my conclusion from this part. Okay, bone-directed therapy is an important part of your armamentarium. Send patients to get their bone irradiated, okay? And in combination with ADT is not likely a new standard of care. I would say it is a new standard of care. Radium-223 you want to give in patients with a good performance status, symptomatic bony metastases, no known visceral disease. Importantly, the lymph node metastatic disease has to be low volume, so this has to be predominantly patients that have bone mets, okay? And they should be symptomatic. And then lutetium can be used in combination with novel androgen deprivation, but not all. So, and again, good data for enzalutamide, not so good data for abiraterone. PET-positive patients, I think it's part of the inclusion criteria. And I think, again, the combination with ARI is likely also a new standard of care. So can we go on to my next slide? I have 7 minutes left, so there's no way I'm going to get through the whole thing, but I'll at least hit on some of the important items, okay? So we'll start with immunotherapy. You tell me when I get to 9:30, okay? So immunotherapy, this is the one form of immunotherapy that is directly FDA approved for the treatment of prostate cancer. You hear a lot about immunotherapy, and we're going to talk a little bit about Pembro, and maybe there will be more data in the future about how it's approved, but right now, CRPC is the one agent that's approved. So this is an antigen, a PAP a conjugate. Ex vivo, the cells are exposed. These cells have been pheresed out of the patient. You go ahead and activate it. You infuse it back into the patient, and then it really helps kill prostate cancer cells, which is very positive, right? Randomized trial showed that it was better than a sort of an they call it Frovenge. They essentially froze the treatment and gave it to them later. And I think there are a couple of important caveats around this. The first is there's no PSA response, which can be very frustrating to the patient, very frustrating to you. But which is more important, the patient lives longer or they have a PSA response? I think we all agree live longer. This highlights just briefly what I said previously, that there was some activity in the control arm, so it's likely that the benefit was even better than we anticipated. Adverse effects, I'll make it simple. They get the flu, so treat it like the flu. You know what I mean? We've all had the flu. You know, you take a lot of Motrin, bed rest, drink a lot of fluid. So, clinicians may offer CRPC to asymptomatic. Remember I said with radium-223 it was symptomatic? This is asymptomatic patients. I'm going to skip through this because of time. Okay, DNA repair mutations. We heard an awful lot about these already. They occur a lot. And what's important about that is Pembro is going to be approved in patients that have defects in DNA repair, in mismatch repair specifically. So this is a study which is in colorectal cancer that showed that patients that had defects in defects in DNA repair did better when they got Pembro. Okay, so as a result of this, they did that was a very small study. They did a larger study, 5 clinical trials, amalgamated all the data, and showed that patients that have a demonstrable defect in DNA repair do better. Okay, they live longer. Okay, and they did a subsequent second study, which was much larger, with 223 patients. It's important to note that only 6 of the patients in this study had prostate cancer. 6. So not a huge amount of data, but and they've tried to expand this utilization by combining with enzalutamide, by combining with using other agents besides Pembro. These are other PD-L1 inhibitors, and I'll make it easy for you. They're all negative, okay? So I'm not going to, again, for the sake of time, everybody here can see that Kaplan-Meier curve is negative. If you focus down on it, it may be that the patients that are PD-L1 positive do better than those that are PD-L1 negative, indicating that if that biomarker is present, the patient is more likely more likely to benefit from the treatment. This is another one, basically showed no difference. So Pembro is agnostic to tumor type. So you can offer it to patients that have defects in mismatch repair or microsatellite instability. And patients that have metastatic disease should be sent for, the tumors should be tested for these kinds of defects. Lastly, PARP inhibition, which is also FDA approved, so you should be aware of it. This is a nice diagram that shows why PARP inhibition works. This is how our body normally fixes DNA when there are breaks. And there are breaks happening all the time in our body, okay? And the body is incredibly good at fixing it. So it can either replace it through single-strand break repair, or it can break the tumor, the DNA fully and do double-strand break repair. And unfortunately, so what a PARP inhibitor does is gets rid of the single-strand break repair. So that makes no difference in the average cell because it can go through double-strand break repair, right? That's what the normal cell does. But if they're BRCA mutated, they can't do that. So the cell dies because it doesn't have the ability to fix its DNA. So the PROfound trial, 2 minutes. So this is a PROfound trial, showed a benefit. All patients, predominantly though BRCA1 and BRCA2 patients, and ATM. This is another drug, rucaparib, showed the same thing, but from the BRCA2 patients, that's the top curve. But if you look at the ATM curve, didn't show a benefit. So again, BRCA1, BRCA2, BRCA1, BRCA2, okay? Now increasingly we're using it in combination. So this is a complex study, but they used abiraterone plus another PARP inhibitor, niraparib, and they used multiple different biomarkers to prove that it was useful in more than just BRCA1 and BRCA2. So here, if you look at the whole cohort, you see a benefit, but predominantly it's in BRCA1 and BRCA2. Okay, I've never seen a curve that looked pulled out all the other HR positive mutations, but my guess is it's going to show no benefit in that group. This is another one, abiraterone versus plus abiraterone plus olaparib, another PARP inhibitor, very similar study design in metastatic castrate-resistant prostate cancer. And again, what you see here is on the left curve, you see a benefit on the intent to treat analysis. But if you look at the the patients that don't have a defect in DNA repair, no benefit. You can sense a theme here. So this is the one that's a little different, and we're getting to the end of my talk. Talipro-2. This is using a slightly different drug that's also a PARP inhibitor, talazopro. I always have trouble saying it. But essentially, the other ones block the interaction of the PARP with the DNA repair apparatus. What this does is sequesters it and degrades it. So it's essentially a stronger PARP. I don't have data in here. One of the ways you know it's a stronger PARP is because the side effects are worse, okay? So what they found is there's an improvement in overall survival when they use the PARP plus enzalutamide versus enzalutamide alone, okay? And what's interesting is on the left curve, okay, it shows if there are no BRCA mutations identified, you still see a benefit, okay? And it's statistically significant. I don't know where it's, yes, statistically significant. And if they have absolutely no HRR alterations detected, it's not statistically significant, but that's the first one where I've seen some separations of the curve favoring the PARP inhibitor. So I think this is going to be interesting as we follow it out longer. And this was data that was just presented at GU-ASCO, so we don't actually know the endpoint. So you need to sequence germline. So in all your patients, you need to sequence germline and tumor DNA, okay? I think the status matters, BRCA1 and 2, okay? The drugs matter, not all the same, and combination therapy is important. So this is the last slide I'm going to show you. You need to offer your PARP inhibitor to patients with deleterious or suspected deleterious germline or somatic mutations, and particularly following treatment with enzalutamide and abiraterone. Thank you very much.
We appreciate your time. I think they do have another course that'll come in here. So if we have any questions, you can come up to the front or we can take it out to the hall area. That way we can be cognizant of the next group that's coming in. Thank you very much and look forward to seeing you next year.